Good morning to all. Today's topic is on iatrogenic periodontitis and Endo Perio Lesions. So first we will deal with iatrogenic periodontitis. The learning outcomes for iatrogenic periodontitis are: examine the term iatrogenic periodontitis, identify various factors and their role in causing iatrogenic periodontitis, select the restorative factors that can cause iatrogenic periodontitis. So coming to the introduction part, what is iatrogenic? Iatrogenic has taken from the Greek language iatros, which means doctor or healer, and genic, there is a gen and means as a result. So what is iatrogenic periodontitis? The factors, that is inadequate dental procedures that add to the weakening of the periodontal tissues are referred to as iatrogenic factors. So the periodontitis that is caused due to the factors, that is the inadequate dental procedures, is called iatrogenic periodontitis. So the foundation for proper aesthetic function and comfort of the dentition is provided by the periodontal tissues. So all prosthetic and restorative therapies largely need a healthy periodontium as a prerequisite for successful treatment. So the relationship of iatrogenic factors with periodontal breakdown was originally recognized in 1912 by Black A. So coming to the details of each restorative factors, first one is restorative factors. Under that, margins of the restoration, contour and open contact, restorative material. So coming to the details of each, that is under margins of restoration, we have overhanging type of restoration, location of the margin, and marginal roughness. Overhanging margins, that is, you all know that this overhanging restorations always inhibit the patient access to remove accumulated plaque. So in this radiograph, you can see that there are overhanging restorations in relation to maxillary molars and the mandibular molars. So which provides, you can see that which provides a space for the plaque accumulation and the formation of bacterial colonization, and also it inhibits the access of oral hygiene. So which changes the ecological balance of the gingival sulcus to an area that favors the growth of disease-associated organisms, predominantly gram-negative anaerobic species, at the expense of the health associated with organisms that is predominantly gram-positive facultative species. Coming to location of gingival margins. So we have different types of margins of restoration. You can see that there can be supragingival marginal restoration, there can be equigingival marginal restoration, subgingival marginal restoration. So this picture shows the preparation, the crown preparation with respect to the margins. There is can be supra, can be equi and subgingival. From the picture itself, you know that the subgingival margins, comparatively the other two margins, subgingival margins always it will go beyond the gingival sulcus, and it will favor the plaque retention, and the microbial shift can be seen here. So in this case, subgingival margins, it will always lead to severe gingivitis by violating biological width and also by inaccessibility of oral hygiene measures. This can lead to severe gingivitis, and also later on, if it get progressed to periodontitis, can lead to deeper pockets also. Whereas equigingival margins, you can see it is just similar as the marginal end, and this will be less severe gingivitis compared to the subgingival margins. Whereas supragingival margins, it is always favors oral hygiene maintenance, and but aesthetically it will be compromised, but also from periodontal point of view it is just the normal, and you can maintain the healthy gingiva. So this is the supragingival is more favorable with respect to perio aspect. So then we have to discuss about, so when we discuss about subgingival margins, we have told that there can be violation of biological width, and also there can be retention of plaque by like reducing the accessibility for the oral hygiene measures. So what is biological width, and what is the significance of this biological width violation? Okay, here we are discussing that this is very important topic. And what is this biological width actually? So this is a dimension of space that the healthy gingival tissue occupies the alveolar bone. So the healthy tissue which gets occupied in relation to the coronal portion of bone is called as biological width. So which constitutes, you can see that in this picture, which constitutes junctional epithelium and connective tissue attachment. So this measurement has been found to be relatively constant at approximately 2 mm. But ideally speaking, when it is comparing the junctional epithelium of normal healthy gingiva, if it is 0.97 mm and connective tissue attachment of 1.07 mm, it either makes the biological width of 2.04 mm. So the placement of restorative margin, it's always recommended to be just 0.5 mm into the sulcus, which allows a maintenance of the biological width. So during restorative preparation, if the apical margin is placed within the biological width that is very close to bone, it is very subgingival margins, there is always like to develop a zone of chronic inflammation. And also this can progress to, that is bleeding on probing, localized gingival hyperplasia with a minimum of bone loss. And if it is get progress, it can lead to pocket formation, gingival recession, clinical attachment loss, alveolar bone loss. So these are the signs of some of the biological width violation. So this space will be maintained by the loss of bone. So that is the result of biological width violation. So coming to the next point, that is marginal roughness. So what are the sources for marginal roughness? There is, which include grooves and scratches. You always know that any grooves or scratches on any rough surface that is forced on the surface of restoration will always favor plaque retention, and then it can lead to gingivitis. Okay, and then it can, and the next point is that inadequate margin fit of the restoration. So the margin typically shows a gap of like 20 to 40 mm between the margin of the restoration and the unprepared tooth surface, which always favor plaque retention. So that you can see that in this space, in this picture, you can see that there is a space between this margin of the restoration and the tooth surface. So this always favor the plaque retention, and this can lead to gingivitis. The third point is that the gap that exposes the rough prepared tooth structure following the dissolution of the luting cement at the restoration margins. There is, you can see that in this scanning electron microscope, there is the porcelain veneer showing a marginal defect and a border of roughened porcelain. And you can see that this roughness, this micro gap, this can favor the plaque retention. So then coming to the next point, that is the contour and open convex. Under there we have over contoured crowns. So under over contoured crowns, it can be buccal or lingual, and then occlusal contours. And the second point is that inadequate interproximal embrasures. Coming to the first point, that is over contoured crowns. So what do you mean by over contoured crowns? You can see that in this picture it shows the over contoured crowns. There is always, it's well known that a well contoured and polished restoration always promotes oral health by resisting the accumulation of food debris and pathogenic bacteria. So in this picture A, it shows that it is the well contoured uh, restoration. So you can see that it always permits the flow of food. Whereas in case of over contoured, it is always leads to plaque retention, you can see. Whereas this under contoured, it will not lead to plaque retention, but it can injure the gingival surface. So that is what over contoured restoration tend to accumulate plaque and possibly prevent the self-cleansing mechanism of the adjacent cheek, lips and tongue. So for the over contoured, that is preventing the self-cleansing, whereas under contoured it does not have that much destructive effect, but under contoured restorations with absent or shallow buccal deflection are said to cause gingival trauma due to injury by rough foot. Okay, so this is the under contour restoration, and this is the over contour restoration. So coming to the details. So coming to the next one, there is the occlusal condos. Condos, it is established by marginal ridges and related developmental grooves. If it is in a proper way, if it is in a proper marginal ridge and if there is any like developmental groove, if it is in a proper way, it will always deflect the food. It will not allow them to retain. So normally they deflect food away from the inner proximal spaces. But if there is any inappropriate occlusal condos, as you can see in this picture, there is no proper occlusal, no marginal ridges and no developmental grooves as in the normal case. So this is always, there is the inappropriate occlusal condos with all the preparations and the restorations. This always leads to food impaction and plaque retention. What is food impaction? Food impaction is the forceful wedging of the food into the periodontium by occlusal forces. The cusps that tend to forcibly wedge food into the interproximal embrasures are known as plunger cusp. You can see that here it is this cusp, that is the mesiobuccal cusp of lower second molar is acting as a plunger cusp to get acting as a wedge to like acting as a wedge to keep the food inside this space. So this leads to food impaction and the inflammation and the pocket formation. So what are the factors that lead to food impaction? So made by Hirschfeld, you can see that it can be due to uneven occlusal wear, open contact area as a result of the loss of proximal support, or from extrusion it can be, or due to congenital morphological abnormalities or improperly constructed restoration. This is very important. What are the factors that lead to food impaction? So you know what is food impaction, what is plunger cusp, and what are the factors that is responsible for it. Uneven occlusal wear, open contact area, congenital morphological abnormalities, improperly constructed restorations. Then coming to the next point, that is inadequate interproximal embrasures. So inadequate interproximal embrasures, you can see that always there will be a black triangle. You can see this in this picture. Always the food will get lodged to it. It will not get deflected. So this will be usually associated with papillary inflammation. So next coming to the next factor, important factor, that is the restorative materials. Restorative materials are not in themselves injurious to the periodontal tissues except one component, that is the self-curing acrylics. Plaque retention capacity of different restorative materials is different, but it can be controlled if the restoration was well polished and was accessible to oral hygiene measures. The undersurface of pondix, you can see that in the undersurface of pondix in fixed bridges should barely touch the mucosa. Okay, but access for oral hygiene is always inhibited if it is very much in contact with the tissue. So they should have a space with the pondic and the tissue to for the self cleansing and for oral hygiene measures. So if it is too much contact with, then the cleaning will not be possible and it will lead to gingival inflammation. Okay. So then coming to the design of removable partial denture. How this design can result in gingivitis or further periodontitis. So the removable partial dentures favor plaque accumulation resulting in, so this can also favor the poor design can be, or ill-fitting dentures can be. So this can lead to gingival inflammation, pocket formation, and also it can lead to mobility of the abutment teeth. So for example, you can see that the retention factors being placed on the adjacent tooth, it can cause injury to the gingiva and it can lead to like inappropriate effect and lead to iatrogenic periodontitis. So for example, partial dentures that are worn during both night and day, which induces more plaque formation than that worn on during the daytime, because nighttime the saliva flow will be less and dryness of mouth, so this can lead to increased plaque retention. The presence of removable partial dentures induces both quantitative as well as qualitative changes in dental plaque, promoting the emergence of spirochetal microorganisms. Next, coming to restorative procedures. Restorative dental procedures, as you know, there can be use of rubber dam clamps, matrix band, burrs. This all can injure gingival gingiva, and it can lead to inflammation. And also, definitely, the forceful packing of a gingival retraction cord into the sulcus to prepare subgingival margins on the tooth, or for the purpose of obtaining an impression, may mechanically injure the periodontium and leave behind impacted debris capable of causing a foreign body reaction. So then coming to the malocclusion, you might have come across with so many cases with malocclusion. So how can it cause problems with periodontium? So obviously irregular alignment of teeth will favor plaque retention, and there will be difficulty in plaque control. For example, it can be crowding, or it can be cross bite or deep bite. So if you tell about deep bite, how it can cause? So with the deep bite, it can always cause traumatic occlusion. That is, it is not conformed to the occlusal pattern of the dentition. So it may cause injury to the supporting periodontal tissues. So this the trauma from occlusion, it can lead to some of the problems in the periodontium. So when you tell about histological factors, there can be widening of periodontal ligament space, reduction in the number of collagen content in oblique and horizontal fibers, increase in vascularity and leukocyte infiltration, increase in the number of osteoclasts on bordering alveolar bone. So trauma from occlusion itself will not cause periodontitis, but it can cause injury, or it can aggravate the present situation. So if the patient is having gingivitis, if with trauma from occlusion, it can aggravate this gingivitis to periodontitis. And also, what are the reasons when you tell about the reasons of occlusal disharmonies? So one of the main important reason for us is that failure to replace posterior teeth. So you can always have a occlusal disharmony or abnormal bite. So for example, after the extraction of mandibular first molar with the failure to replace, you can see that initial change is a mesial drifting and tilting of the mandibular second and third molars, and always obviously there will be extrusion of the maxillary first molar. So as the mandibular second molar tips mesially, its distal cusp extrude and act as a plunger cusp for foot impaction. So the distal cusp of mandibular second molar wedge between the maxillary first and second molars and open the contact by deflecting maxillary second molar distally. So this is very clear from this picture how it is the occlusal disharmony leading to foot impaction and to gingivitis and finally to periodontitis. Then coming to periodontal complications that are associated with orthodontic therapy. So there can be indirect effect or direct effect. When you tell about indirect effect, obviously there will be favoring plaque retention and foot debris, that you know that for the patients with fixed orthodontic therapy, always oral hygiene maintenance is a target, and this will lead to plaque retention debris, and that will modify the gingival ecosystem, that will result in gingivitis. And the direct effect, it can be if there is excessive or unfavorable forces on teeth. So there can be a negative effect on the periodontium. For example, excessive force produces necrosis of the periodontal ligament and adjacent alveolar bone, which increases the risk of apical root resorption. And also this orthodontic bands placed on newly erupted permanents with still attached junctional epithelium on enamel will result in apical migration and proliferation of junctional epithelium and an increased incidence of gingival recession. So when you tell about periodontitis patient, there is okay, always you can expect a bone loss of like zero point 0.1 to 0.5 mm that is in a normal way, like those who went 2 years of orthodontic treatment. But if there is any degree of bone loss, if there is any bone loss or periodontitis case, always you have to treat the patient first, and at least 6 months there should be stable periodontium, and then you can go for the orthodontic therapy. So the degree of bone loss during adult orthodontic care may be higher than that observed in adolescents, especially if the periodontal condition is not treated before initiating the orthodontic therapy. Okay. Coming to the extraction of impacted third molars. How this extraction of impacted third molars can result in periodontitis? This can it can create a vertical defect distal to the or adjacent to the area, that is, it is usually with the impacted third molars, it can lead to defect in the distal to the second molars. So it appears to occur more often when third molars are extracted in individuals older than 25 years. So this can lead, if it is not getting proper care, this can lead to again food impaction, food retention, and it can lead to periodontitis. So habits and self-inflicted injuries. You know that this injuries that is purposely causing or unknowingly causing or accidentally causing, this can injure gingiva and periodontium. So there is a toothbrush trauma can be, or chemical injury can be, or tobacco use. That is also, there can be some accessories, jewelries. Nowadays you can see that some of the jewelries that are using that also can cause harm to injury to periodontium. Then coming to the radiation therapy, as you all know, this has cytotoxic effects on both normal and malignant cells. So this induces obliterative endarteritis, resulting in soft tissue ischemia, fibrosis, hypovascular and hypoxic bone osteoradionecrosis, dermatitis and mucositis, and can cause muscle fibrosis or trismus, xerostomia, caries, periodontal attachment loss, and teeth loss. So these are some of the factors that can be caused due to this radiation therapy. Out of that, one of the factors is periodontal attachment loss. So coming to the next topic, that is important topic, Endo Perio Lesions. So we will be taking a short note on this, but the details you will study in cons department. So the learning outcomes for Endo Perio lesions are: classify Endo Perio problems based on 2017 classification, apply your knowledge in differentiating the clinical features of pulpal and periodontal problems, select the treatment options or treatment plan for a given scenario of an Endo Perio lesion. Coming to the definition of Endo Perio lesion, what is an Endo Perio lesion? This is a definition given in 2017 classification, periodontal and peri-implant diseases classification. So what is an endoperio lesion? It is defined by pathological communication between endodontic and periodontal tissues in a given tooth. So this classification differentiates whether the lesions with and without root damage. So before going to the details of two types of endoperio lesions, that is with and without root damage, what are the pathways of communications? It can be apical foramen, laterally and accessory canals, dentinal tubules, and palatogingival grooves. And non-physiological pathways can be, it is because of vertical root fracture and perforations. So these are the different ways that leads to the communication between endodontic and periodontal tissues. So coming to endoperio lesion with root damage, it can be due to root fracture or cracking, root canal or pulp chamber perforation, and external root resorption. And the other type, there is endoperio lesion without root damage. So these can occur in periodontitis patients or in non-periodontitis patients. So in periodontitis patient, it can be graded according to the involvement of tooth surface and the severity of pocket depth. So that is, it can be narrow, deep pocket depth in one tooth surface, wide, deep, narrow periodontal pocket in one tooth surface, and grade 3, that is a deep periodontal pockets in more than one tooth surfaces. And in non-periodontitis patients, it is grade 1, there is a narrow, deep periodontal pocket in one tooth surface, wide, deep periodontal pocket in one tooth surface, and deep periodontal pockets in more than one tooth surfaces. Endoperio lesions with root damage. So, as we told before, these lesions are associated with traumatic or iatrogenic factors, root fracture like root fracture or cracking, root canal or pulp chamber perforation, or external root resorption. And those without root damage, this can be of either with the periodontitis or non-periodontitis. That is, non-periodontitis, that it can be due to endodontic infections. So they can be caused by an endodontic infection, that is in case of caries lesion, and that can secondarily infect the periodontium, or a primary periodontal destruction that infects the endodontic secondary. It can be in either way, or it can be a combined lesion also. Okay, so lesions with primary periodontal origin have a lower prognosis than those with an endodontic origin. Okay, so endoperio lesions may develop in patients with or without periodontitis. This can be clearly explained by the classification given by Simon, that is primary endodontic lesion, primary endo-secondary perio lesion, and primary periodontal lesion, primary perio-secondary endodontic lesion, and true combined lesion. So the first one is primary endodontic lesion, that is an inflammatory process in the root canal system. So from the pulpal infection, when it leads to the inflammation of periodontal tissues, that is primary endodontic lesion. And the second one, that is the primary periodontal lesion, there is the periodontal problem, there is the loss of periodontium, periodontitis, if it is leading to the pulpal inflammation. So that is the primary periodontal, but the pulp will be vital, so it will cause inflammation in the pulpal tissues. That is the primary periodontal lesion. Then what is primary endo with secondary perio? That you can see that. So the primary endo, there is the pulpal inflammation or pulpal necrosis, so which leads to a sinus tract, and which causing progression of periodontitis or retrograde periodontitis. You can see that this infection from the root canal system, it is getting drained through the periodontal ligament space, and this causing secondary periodontal involvement. And the next one is primary periodontal with secondary endodontic lesion. There you can see that this occurs when like periodontal disease causes simultaneous pulpal necrosis as the disease progresses epically. It can be due to the apex, that is from the apex, that is from through the accessory canals, and this can lead to pulpal necrosis and pulpal involvement. So there is then next coming is the true combined lesion. So there is no like involvement of endoperio, but this can be a combined lesion. So this can occur that there will be caries, and also there will be a periodontitis. So they develop independently and simultaneously. So they will meet at a point. So you can see that from this picture, from this it is coming to the perio, and from this it is coming reaching to the apical side. So at a point it will meet. So there is a true combined lesion. So coming to the diagnosis, the diagnostic approach to periodontal endoperio lesions, therefore always will be carried out by the new classification. That is, they have to rule out whether there is endoperio lesion is due to the root damage, associated with root damage, or endoperio lesions without root damage. So we will be dealing with the diagnosis and followed by the prognosis and treatment plan. The first step is that it is to rule out the root surface integrity, the loss of root surface integrity. So if it is present, and that based on the patient's oral history is very important in order to identify any trauma or any endodontic and radicular restoration treatments that may be the cause of iatrogenic injury. So if there is any traumatic or iatrogenic event that is identified, then we can go for a clinical and radiographic examination, so to reveal the presence of an endodontic perforation, fracture, or root resorption. So if it is identified with the cause of traumatic or iatrogenic event, then the prognosis will be very low, and the treatment is often ablation or root amputation of the tooth. So when you just detect the root damage, always you have to make sure about presence of palatal dental invagination. This can give you misdiagnosis. Why? Because this can mimic a vertical root fracture in radiography when a periodontal lesion is located at this anatomic feature. So second step is that once root damage has been ruled out, a thorough examination of the current periodontal status must be performed. The patient will be placed in the periodontal disease context or not, and the prognosis will be depending on the presence, on the severity of the disease, on the destruction, on the periodontal destruction. So if it appears that the tooth can be maintained on the arch, the management record for these lesions always will be included the endodontic and periodontal treatment. So coming to differentiating the clinical features of pulpal and periodontal problems. So they have to rule out whether it can be primary endo or primary endodontic, secondary periodontic. So how we can differentiate these all involvement, or these all type of endoperio lesions by all the clinical features. So it can be differentiated by pain, swelling, periodontal pocketing, radiographic examination, and vitality. The first one is primary endodontic. The pain will be moderate to severe, And this primary endo, secondary perio also, like moderate to severe pain will be. And always this perio involvement, it will be like every time it will be moderate. Anyway, compared to endodontic, it will be less. In perio case, combined pulpal and periodontal is also moderate to severe. Coming to swelling, this primary endo, the swelling can be possible. Uh, Primary endodontic, secondary will more likely to occur, and primary perio, secondary endo can be possible, and this combined pulpal periodontal more likely to occur. Okay, so coming to the periodontal pocket, as you know that primary endodontic, none, this there will not be any periodontal pocket unless sinus tract, and primary endodontic, secondary perio, it will be evident, or sinus tract will be evident. And primary periodontic, you will get a moderate pocket depth, and primary endo, secondary endo, you will get a severe pocket depth, deeper pocket depth. Okay, and combined pulpal periodontal, you can get pocket depth that is severe and which connects with the periapex. Okay, so coming to the radiographic, there is a primary endo. You can see that possible periapical radiolucency, but it will be very mild. Not, it can be possible because there is only the primary endo that is causing the periodontal inflammation. And other one, primary pendo, secondary, definitely there will be radiolucency from the apex to the sulcus, which decreases the crustal bone height. And primary periodontic, there will be decreased crustal bone height. And primary perio, secondary endo, bone loss that will approach apex. And combined periodontal, pulpal periodontal, bone loss extending to apex. So coming to the vitality, all the endodontic involvement that will lead to non-vitality of pulp, the negative response. And whereas primary periodontal with secondary endodontic, the vital pulp, this will be, and for the combined it will be non-vital. So coming to the treatment plan and prognosis of periodontal endoperio lesions, the first one, there is a primary endodontic lesion. So this can be treated by root canal treatment, and usually this primary endodontic lesion will get resolved with the root canal treatment alone. So the prognosis will be good. Whereas for primary endo, secondary perio, always it will start with endodontic treatment, that is a root canal treatment, followed by the treatment of periodontitis, there is a basic periodontal therapy. So it will get treated by basic periodontal therapy. So this prognosis always depends upon the endodontic treatment and periodontal treatment, and always with the patient response. So primary perio with the secondary endo, so you can do with the supportive periodontal therapy, there is a scaling, and always it will lead to root canal treatment, and after 3 months you can go for advanced periodontal therapy, that is with the GTR, growth factor, and or enamel matrix derivatives, all the components for regenerative therapy. If it is cannot be like if there is no patient reduced patient response, or if there is advanced periodontitis that cannot be treated with regenerative procedures, always it will go for extraction or root amputation or hemisection. And the same thing happens for true combined lesion also. It starts with the supportive periodontal therapy followed by root canal treatment. Then after that, after 3 months, there will be advanced periodontal therapy with regenerative procedure if it is with mild to moderate. If it is advanced periodontal diseases, then it will lead to extraction or root amputation or hemisection. So this will always depends upon the severity of periodontal disease, the prognosis, and always with the patient response. So next is a primary periodontal lesion, that is with the periodontal therapy. First one, phase 1 therapy. If it is not getting resolved by phase 1 therapy, it will lead to surgical therapy. The prognosis always depends upon perio treatment and patient response. So this is a decision tree for endoperio lesions and the prognosis. Okay. So that's all about endoperio lesions. So today we have covered iatrogenic periodontitis and endoperio lesions. Okay, that's all for today, and thank you.